Good morning, good afternoon, and good evening, everyone. Welcome to our 33rd webinar. I'm Niti Dasturi here on behalf of the Circle of Cleft Professionals. Today's webinar will focus on isolated cleft palates, the complexities around this condition, and how early detection practices could be applied to low and middle income contexts. We will be having simultaneous interpretation in Spanish for the entire duration of this webinar, for which we have Ben and Eva joining us from Chile. At the bottom of your screen, you will see an interpretation button. If you would like to hear the rest of this webinar in Spanish, please click on that button and select Spanish. For optimal participation on this webinar, if your bandwidth allows, please keep your video on. Feel free to use chat to introduce yourself to the group and let us know where you're from. Please keep yourself muted when not addressing the group. Once the panel presentation is done, we'll open for discussion where you can post your questions either via chat or on video by raising your hand. So this is how today's webinar will flow. We will begin this hour-long webinar with a quick COCP update. We will then have a panel presentation by Dr. Alex Hubble from UK, by Dr. Parakrama Vijaykun and Dr. Tanuja Herath, who are joining us from Sri Lanka. Once the panel presentation is done, we'll open for discussion. So the remaining half hour will be for questions, comments, discussion, and closing. We have three core objectives at the COCP. Our aim is to facilitate networking and collaboration amongst cleft professionals to communicate the learning and impact that's happening within cleft care and to support the growth of local teams in implementing comprehensive care. Our membership is constantly growing. We have over 660 members belonging to a wide range of specialties within cleft care. Our largest membership group is cleft surgeons at 190, followed closely by speech therapists at 151. As you can see here, our members are spread across the globe. These are the 81 different countries that our members come from. A shout out to these 11 international charity organizations, all of who have come together to make the COCP and all of its activities possible. Over to you, Hugh.
Thanks, Niti. My name is Hugh Brewster. I'm here in Toronto, Canada on behalf of the Circle of Cleft Professionals and delighted to welcome you to our 33rd webinar in this series. We've obviously had many more than we initially expected, thanks to the pandemic, if that can be a bright side. And another really bright side is seeing this community of people who are so committed to cleft care to be able to spend some time together. So if you haven't already, please do type your name and your location into the chat. It really helps guide our discussion. And without further ado, I just want to introduce our topic for today. And this is something that I didn't know that much about. So, I mean, I've been at Transforming Faces in Toronto for about 5.5 years, and I really had not, it shocked me to read Dr. Alex's research a little bit about this 30% of isolated cleft palates that were going undetected in the UK. And, you know, that was a shocking number to me. So we're here today to discuss a little bit of what the learning has been from the Royal College of Pediatrics and Child Health as they introduce this best practice guide, with Dr. Alex being a prime mover in that forward. And we're going to hear a little bit more today about his work as part of a team and moving this forward in the UK, but also what we might be able to learn in LMAC contexts. And I'm really delighted that he's invited two of his close colleagues, Dr. Parakrama Vijaykun, who's a senior consultant in oral maxillofacial surgery in the Faculty of Dental Sciences University at Peradeniya, Sri Lanka, as well his colleague there, Dr. Tanuja Herath, who is a consultant pediatrician and senior lecturer at the same institution. So Dr. Alex was the first consultant cleft lip and palate pediatrician at Great Ormond Street Hospital for Children in London, and has also had this long experience, 20 years as a member of the Sri Lankan Cleft Lip and Palate Project. So we're delighted that you're here. I hope you'll be thinking about your own context and some good questions that you'll be able to ask as we spend, as Niti mentioned, about 30 minutes discussing what can we learn from the UK? How might this apply to our own context? What questions do we have about moving forward to deal with this really important topic of isolated cleft palates? So I'll pass the mic over to Dr. Alex to kick us off.
Right, thank you very much for that very nice introduction, and thank you very much for suggesting, you know, that Transforming Faces should host this webinar. I'm really delighted to take this opportunity because as you'll discover, I hope that I've got ulterior motives as well. So if I can, there have been some little glitches to begin with on my part, but I'm hoping that if I post this now and give it to you as a slideshow, that we will be able to see it, and we will go from here. And I'm so delighted to be reunited with my two colleagues who I was very close with, and I'm delighted to say that I hope it's not a secret, but they are actually even closer colleagues since they happen to be husband and wife. The thing is that we worked together, as you know, in the Sri Lanka project and in the UK when they came here for part of their training. So although not involved with the survey itself, they clearly use your findings, our findings, in your work in Peradeniya in Sri Lanka. So the talk, Delays in Referral of Isolated Cleft Palate, Learning from the UK's Successful Detection Programme, took about the best part of 15 years to be fully road tested. The guidelines arose from the concerns of families and clinicians about delays in detection of weeks, months, sometimes even years in what we thought was a well-organized, high-income country's National Health Service. So these college guidelines for best practice have improved the likelihood of early detection. I've got a particular reason for presenting them to you because I do hope to learn from you. Our hope is that this webinar will help deliver its practical message, which can be modified with your input in a way that works for professional carers of infants and young children in your communities. So do please be ready to give helpful comments towards the end of the presentation. I'm really looking forward to the discussion. So just a reminder, the worldwide incidence of cleft lip and palate is 1 in 700. Isolated cleft palate without cleft lip, the mean figure for occurrence is 1 in 2,000 births. The ratio male to female, the reverse of that for cleft lip and palate is of 1 to 2. You're aware of how the rate seems to vary across the globe, and you'll see from the histogram on the right-hand side how it varies according to ethnicity, so that it's highest in Canada and Finland with American Indians and Alaskan natives, but not by much compared with the lowest, which is people from the African continent. So isolated cleft palate has the highest association, or cleft lip and palate groups, for congenital abnormalities at 30 to 50%, so-called syndromic. So an important handle to identify other anomalies, the commonest being the Robbins sequence, others being those with congenital heart, the 22q11 deletion syndrome, Stickler syndrome, fetal alcohol, van der Wood, skeletal dysplasias, and you'll know that there are literally hundreds of other associations. And now I'd just like to introduce to Noor Jaharat and ask if you could talk a little bit about why is early detection of isolated cleft palate so important?
Okay. Thank you, Dr. Haber. It is very essential that we all know, it is very essential to detect the isolated cleft palate as early as possible, because it has to, because it is very important that you ensure adequate as well as safe feeding, because this defect is associated with recurrent aspiration of milk, which leads to is aspiration pneumonia, and also recurrent middle ear infections. And also because it is, as you said, it is associated with a lot of other congenital abnormalities, detection of isolated cleft palate is important, so that we are aware and we are alert about looking for other congenital abnormalities in these children as early as possible. And feeding and nutrition is extremely important, because we all know that within these 2 years is a very, very important period where you need adequate nutrition for the future development and for ensuring the human potentials in its maximum and adequate amounts. So, and also if we detect this earlier, we are able to arrange the parental support to explain them and to counsel them and to say what they should be doing and what our program is. And it is essential that we as early as possible diagnosis for ensuring adequate weight gain, which is essential for surgical correction, and therefore for early surgical referral, it is very important for diagnosing it as early as possible.
Lovely.
So,
Thank you so much. Thank you so much. Right. So thank you, Tanuja. So just to say that the next thing that we looked at was looking at a survey and how it all started. It was 1998, the UK parents of the Cleft Lip and Palate Association, CLAPA, did a survey and found 10% of cleft palates had not been picked up when first examined at birth. That was the parents' report. So I looked at the clinic records at Great Ormond Street, which confirmed that actually it was not 10%, but 30% at the first baby examination. So the UK National Cleft Register, which we call CRANE, then began to collect the data. And over the 10 years that leading up to where we are, the rate remained the same, 30%, and 20% at 72 hours. That's the longest period that would be allowed in the UK in terms of baby examination in the newborn period in that way. So otherwise, in Norway and in Holland, as an example of two European countries, they are actually in the same boat with what we would consider, I think, in the cleft community as being unacceptable delay. In the UK, the aim is amongst the cleft surgical community to diagnose, have ideally clefts diagnosed within the first 24 hours of life. But I think that that's actually, perhaps that's going to be a bridge too far for our neonatal services as they stand. So anyway, so we then reported this in 2005, and at the same time, we looked at why clefts were being missed. And it seemed the characteristics were of a narrow cleft, and posterior clefts were less likely to be detected early. And a normal looking baby is twice as often missed as one that looks a bit syndromic. So that's quite interesting. Now, the question was, you know, WHO, which we actually thoroughly respect, we wondered what they might be saying. So WHO says the responsibility for examination and standards is unclear, a sort of no man's land, how they put it. So is it the pediatrician? Is it the dentist? And I would add, or the nurse or the midwife, who's responsible for detecting clefts early. So this was then followed by a recommendation that palates be examined by transillumination using a light and digital examination, palpation, feeling. But where was the evidence? That was the thing that I started on. Well, which method is best? Or should we use both? And how and when? And so systematic studies were lacking. So we started to investigate. Firstly, we questioned the palate examiners, junior doctors and midwives in hospitals in and around London. Almost half of doctors relied on palpation only, as did most midwives. And some did both palpation and looking, and many didn't seem to be that well trained, quite honestly. And so we decided we had to do a little more delving, and we trialed the use of life-size orthodontic models, 3 different sizes, the neonatal cleft being small, medium, and large, as you can see on your screen. The results were that comparing them with 4 non-cleft molds, and we gave them names here by initials and jumbled them up, and the idea was that they could look at them and then they could palpate them, and we could compare how they got on doing the identification. So in fact, the junior participants, medical, nursing, and midwifery staff, mostly correctly identified on visualization, 95% on visual examination, but on palpation, it reduced to less than 50%, identifying all three clefts correctly. So as one remarked, a fingertip is examining literally in the dark. I mean, you're just feeling it. So even large clefts could be missed by palpation. Participants who misdiagnosed a large cleft often felt the vomer of the nose as if it was the hard palate. So this seemed to make a significant impact, because after handling and looking at the models, the same groups attempted identification by palpation. A few days later, I went back and they did improve, but many clefts were still missed on palpation. So the message, I think, is pretty clear that the logical conclusion, the whole length of the palate must be visually inspected. So Para, I'd like to ask you if you could then now take over this question of where does submucous cleft fit into this?
Yeah, thank you, Alex. Actually, it's very important to detect the submucous cleft, because when you open the mouth, the normal cleft can be visualized, but you might miss submucous cleft if you are not properly examined. So as you see in the middle triangle, the white line or the bluish line denote the oral mucosa and the nasal mucosa joining together without any muscles. Muscles are actually like a normal cleft. They are attaching into the back of the hard palate. So that is a one sign. Second thing, and the two arrows shows the posterior nasal spine. If you palpate in a normal patient, you will see single posterior nasal spine, but in a cleft, it's divided in two sides. And in addition to that, sometimes you get a bifid uvula, as you see in the third picture. So the submucous cleft sometimes even missed by the specialist even. And it's very important with the submucous clefts, when the patient is growing up, they may have a nasal regurgitation, or they may have a speech problem, growth retardation, and then the middle ear infection. So it's very important to follow up the patient. Sometimes the mothers may come up with the certain symptoms. Then it's very important to examine the palate with the proper light, visual examination, as well as physical examination. That's by the palpation with the finger to detect the submucous cleft. If any of those signs are there, then definitely it's an indication for surgery. But very important fact to remember, so in a normal submucous cleft, the mother or the guardians will see it as a normal cleft because they don't see any defect. But as the clinicians, we know it's a submucous. So the chances of fistula formation in a submucous cleft reported to be 1/4, that is 25%. So chances of getting submucous cleft treated with a fistula formation is very large. So that we have to discuss with the parent before embarking on the surgery. Otherwise, they might say the surgery itself caused the defect. So it's very important. Okay.
Thank you very much. Yes, thank you very much. And just to sort of underline that, in Europe, the average age for detection, for instance, in Holland, is 3.5 years. So we know it's extremely difficult to diagnose and find until symptoms really become so prominent rather than actually physical signs. And again, it's the expert, it's the cleft surgeon who has the job of identifying that usually. So we brought together all the stakeholders, the parents, midwives, nurses, cleft surgeons, neonatologists, and pediatricians to review the literature. So this became an expert group and recommendations were arrived at by consensus. The process was approved using the National Institute for Clinical Excellence, NICE. I don't know if you've heard of this particular acronym, but it is very highly respected in the UK as being authoritative on many educational, medical, and therapeutic methods. So this was a best practice guide through those recommendations. 1, examine the hard and soft palate in every newborn infant, record this in the child health record. 2, visually inspect the whole palate. 3, use a good light from a torch or mobile phone and a tongue depressor to visualize the whole palate. 4, inform the parents if the whole of the palate is not seen. This is really important. If a whole palate is not seen, to examine it again in our system within 24 hours. But we agreed that actually this could certainly be done outside the hospital in community settings, as long as the people were aware of what they were being asked to perform. And also how important it is that centers should train all examiners, that is to say, all professionals involved in the care of infants who would be likely to examine, that they should be properly taught. Right. Tanuja, back to you about visual inspection as part of newborn examination.
Yeah, the newborn examination is basically to assess the health of the baby at birth, regarding the maturity, the growth of the baby, and also whether the fellow is vitally stable, and whether there are any congenital abnormalities that you should attend to as soon as possible. So that is the basic idea of doing a neonatal examination soon after birth. In our setup in Sri Lanka, I would say every baby born is, almost all the babies are born either in a tertiary hospital or a secondary hospital where there is a pediatrician and also a VOG. Very rarely, only very few are born in rural hospitals, also where there is a doctor. And the general routine is every baby is being checked by a doctor within 24 hours. So some of the babies with cleft are being detected at birth, and especially when they are born by cesarean section, there is either a trained pediatric HO there for the at the time of delivery, where he detects the or check the palate as well, along with the newborn routine examination. And after most of our babies are being detected within 24 hours, because in the routine examination they do the palatal examination as well. Lovely. And these babies get discharged normal deliveries. After normal delivery, these babies get discharged at 48 hours, and after they go home, within the first week, a midwife home visits and check the baby, especially with regard to feeding. And there is another check by the midwife, a home visit at the end of the second week. And there are 3 visits by the midwife before the baby goes at 1 month to be seen by a doctor. So all these visits are to assess the baby's normal well-being and to detect any congenital abnormalities. So out of interest, the babies who come to our center for cleft surgeries, I always ask where the baby was born and where, when, and who detected the cleft. So it is almost, in 75% or so of these babies have been detected by the doctor. And some of them have been detected by the midwife. That is also with the babies, when the baby cries, and by directly visualizing when they see any difficulty in sucking, feeding. So these babies then get, if there is any issue, the midwives, whether it is due to cleft or any other reason, if there is any issue with regard to feeding and general well-being, any change in color or something, they will be getting referred to a doctor from where the pediatricians have the opportunity to see them. So I think there is a lot of, very rarely it is missed in our setup more than 1 week.
Right. Well, actually, that is an extraordinarily profound and excellent safety net. Enviable, I have to say, and I wish it was as good as that in the UK. And you have an enviable neonatal mortality rate as well, certainly for your part of the world. And this obviously accounts for it. But this is now to go on the best practice guide was rolled out by the college with its partners in 2015. And you can see here the partners, the GPs, the perinatologists, the parent association, the craniofacial surgeons as a group, midwives, and the college of pediatrics itself. And the question is, well, what's the payoff? Well, here we see these on every year, 400 babies with isolated cleft palate are born in the UK. And this graph plots the rate of detected cleft palate within the national standard of examination within 72 hours of birth. Percentages on the vertical, and on the horizontal is the years. And you can see the range shown is a little narrow for illustration, but it goes from 80 and up to 91% are detected by the end of the first week, according to the report of this year from Crane, our national register. So we can understand that actually this does seem to be a significant improvement and is close to where I think we probably can get, bearing in mind that the ones that are now being missed in general are very small and generally picked up later because of symptoms. So we looked at how rates could be improved, and the first thing was that change should be led by yourselves, people like you who are senior clinicians, people that are examples and are educators. And there were other additional things, but the two really important things that improve rates are that the baby is held correctly using assistance by a carer or staff person. Too often it happens that a doctor or nurse would examine without holding the baby correctly because they don't have assistance. And I think that the mother is a very good assistant if shown how. And appropriate equipment, spatula and good light. Okay, and now the ownership of the process was also extremely important because every year the annual data is collected from each of the 12 cleft centres across the UK. And although rates do vary by area from year to year, if the hospitals begin to own it, as happened in one English hospital district, the midwives decided to make it a special goal to check every baby palate at the first feed after birth. So after the baby being taken to the breast on the first occasion, it would then on the second occasion have the palate looked at. This has resulted in no clefts being missed for 5 years from a very significant large area in the south of England. So ownership of the process is a very important motivating force, and the midwives of Medway are rightly proud of their record. Now, I just want to go to areas which are perhaps much more relevant to yourselves, which is what is the proportion of isolated cleft palate in LMICs? I've been unable to find national registers for cleft lip and palate in LMICs, but I'd be grateful if you could direct me. I looked for clues through reports from hospitals and NGOs. And one extreme example is that of Uganda, where only 2% of those who come for cleft lip and palate surgery were cleft palate cases, according to Doctors Wilson and Hodges, who asked in 2012, where have all the palates gone? That's a hugely important question. We know that Africans have a lower incidence, but could it account for this? Assuming the same proportion as the rest of the world, 30% isolated cleft palates, where are the other 90-odd% missing from the Uganda survey? Well, the question was, Hodges thought they might be dying before coming to surgery or just didn't come. So this has got some support from a survey of public hospitals in South Africa, where the patient population was 2/3 African and 1/3 other ethnicities. There, the cleft palate was actually 30% of all cleft lip and palate, the global average. Another Ugandan hospital center found 25% of cleft palates had additional abnormalities at birth, but only 8% actually presented for surgery. So was this due to abnormality being life-limiting if appropriate interventions or support are not available? Well, a Smile Train survey, the Smile Train survey, Smile Trains everywhere, and does thousands upon thousands of surgical cases and collection of over 300,000 African cases of cleft lip and palate found only 7% had cleft palate. And the ratio of male to female, as you can see, is instead of it being the 1 to 2, is almost unity, which suggested the conclusions that they came to. The limitations in economic sources and stigma of visible lip deformity are hugely influential. Speech, education, and employment seem less important in females. And I think this sadly reflects many aspects of our societies. But that is probably an unassailable fact. So why does it matter? As control of ancient killers of children by infection across the world have improved, the proportion of children with congenital abnormalities requiring care has correspondingly increased. And I'd just like to point out that if the higher income country experience that we have had of inconsistent examination also occurs in LMICs, as reported in Uganda, and also in the report, one from India that I quoted there, the worldwide underrepresentation of cleft palates could be significantly larger. And this is just to sort of, on again, that slide, which shows the difference. The dark columns are the cleft palate, and you can see that actually, on the whole, it's 6 per 10,000 births for whites and Hispanics, Asians, and 4 for Black Africans, so that actually there should be a very significant number of cases that are not being identified. And we have got to do something about this. Now I'm going to take us to the cleft palate examination, just so that we can actually have a little look at what we do from the point of view of triangle education. All right, so here we are. I hope this will play for us. And I'm just going to click it. This is from the Royal College's website, which you can visit and download this particular e-module.
Alex, we don't see your screen right now. I think you need to reshare your screen.
Okay, sorry. I do apologize.
It's not a problem.
You got it now?
You see it now? Yep. We'll just listen.
Good. Okay, here we go. After the first examination of infants with a cleft palate, without cleft lip, is between 1 in 3 and 1 in 6 in England and Wales. Attention to correct technique can shorten the time of referral for expert assessment, feeding and emotional support, and treatment. Visual inspection is the most reliable way of identifying structural abnormalities in the mouth affecting the gums, palate, and tongue. Cleft palate may be suspected when there are feeding difficulties. Milk coming out of the nose during feeds, not only when winding or regurgitating, as in this baby, who is making noisy wet sounds while feeding, and a trickle of regurgitated milk is coming from the right nostril. There may be breathing difficulties caused by the tongue falling back into the palate defect. The tools needed are a good light, such as a pen torch and a tongue depressor, either a wooden spatula, plastic spatula, or sterile 1 ml syringe. The infant's arms may be restrained by an assistant or the mother, after explaining the purpose of the examination. For example, hold the arms gently and firmly on each side of the head, or restrain the head with one hand, while the other holds the baby's 2 arms as they are gently pulled together on the lower part of the chest. This allows a clear view of the mouth to look for possible causes of feeding difficulties. The tongue is pressed down under direct vision, placing the spatula or 1 ml syringe towards the back of the mouth when it may elicit a gag reflex. Avoid pushing the depressor into the back wall of the throat. Look at the whole of the palate, including the uvula, for a cleft of the palate or bifid uvula, and from front to back of the mouth for a cleft of the gum, neonatal teeth, and abnormal size or shape of the tongue. A short frenulum is common in the newborn, but it is unusual for it to cause tongue tie sufficient to interfere with feeding and requires further assessment. A cleft of the palate extends from the back of the palate towards the front of the mouth. It may involve the soft palate or extend forward to include the hard palate almost up to the back of the gums. The cleft in this baby is a large cleft involving the hard and soft palates. The following pictures show a selection of appropriately larger and wider clefts involving the soft and hard palates. This shows a narrow cleft of the soft palate. A complete cleft of the soft and hard palates is shown in this picture. This, a wider cleft of the soft extending into the hard palate. A wide U-shaped cleft involving both palates is present. Right. Now, I'd like to take you on, if I may. This shows you best practice, some little ideas on what to do, and the student or practitioner is advised what to do here. Avoid the gag reflex, placing the spatula towards the back of the mouth. Little things which are obviously really important. A second examination, which I referred to, if you don't see it at first, what to do. Now, this is for the UK, and I'm interested to know how it might work in other locations. What to do if the visualization of the palate is insufficient to exclude cleft palate? Examination is not always successfully completed. The mouth being small, the infant, although restrained, may be upset, and the examiner may subsequently desist. So some babies' palates will not be fully visualized. The parents should be informed of this and further inspection advised. This is an essential safeguard in the drive to reduce unnecessary harm caused by delayed detection. The role of the Personal Child Health Record, the PCHR, can be central to achieving this objective. On page 2 of the 2015 version, under Birth, Details and Newborn Examination, in column 1, item, enter incomplete. In the column Guide to Content, circle palate or write palate. Column Results, write not fully visualized or not seen completely. Column Action Taken, tick yes and write Follow up advised. On page 3, tick Follow up required. Under Location or Clinic, insert your local arrangement: Pediatric Clinic, Newborn Review Clinic, or Child Health Clinic. Under Reason, write Check palate is fully seen. Having filled in the PCHR, make sure the carers understand the arrangements in place for the inspection to be completed. Alternative strategies might be a stamp advising review to be put into the page, or a printed slip to be stapled into the PCHR. Finally, looking in the mouth is the best way for examiners to identify abnormalities. Finger palpation is complementary and not a substitute. If you are uncertain about the appearances, ask an experienced examiner. If the whole palate has not been visualized, arrangements must be made for its re-inspection. There we go. Right. There we go. Stop that share and then just very briefly go back to the presentation, if I may. There's a mother's testimony about delay. You can see here, this was a 3-year-old with a cleft of the palate that came to the clinic years ago. And this was mother's testimony about the many difficulties that she had and the family had in convincing doctors that there was something wrong with her baby. At the end, they get the student or practitioner gets a certificate of completion as an incentive, and in summary, why visual examination matters, delay affecting growth, disability, education, genetic advice and family planning, really important, looking increases life chances, best practice guidelines make a difference, and the true incidents may not be identified unless looked for. I mean, you know, this is important. Now, I invite Tanuja and Para to sort of have a little, should we open this up now for discussion?
Yes, Alex, I think it'd be great. The video and audio came through. It was very helpful. And we do want to spend some time hearing from the community, but we can definitely start with our esteemed colleagues from Sri Lanka. How do you see, obviously, as Alex mentioned, there is a strong safety net already in place in your practice. But how do you see the kind of learning from the UK experience being applicable to your context in terms of isolated cleft palate? Oh, you'll just need to come off mute.
Well, the best practice guidelines are being sort of practiced. I mean, it is being routinely done in our setup by the doc, because I think it is because the doctors are the ones who have taken the responsibility of examining the newborns here. It is mostly the doctors, so therefore they are mostly in accordance with the guideline, and even in the medical students, the final year medical students, they very frequently get a newborn examination for their final year exam. So they are quite they are quite confident, and they are well trained to do this. So I would say the palpation method may not be very frequently practiced. It is mostly the visualization by direct transillumination that is being practiced here. And also in difficult, when it is not very easy to see the full length of the palate, I think it is not a bad thing to make the fellow cry a little bit with open, fully open mouth, which is not as difficult as putting a tongue depressor by a not very trained person, because as Dr. Hebel said, it can induce a gag reflex, and the fellow is more uncomfortable. But even I used to tickle a little bit so that the fellow just howls, and then it is easy to see the whole length. So that is, I think, that is also a bit of a easy thing to practice and not miss a palate, cleft palate.
Thank you.
So yeah, I think, and also this, as I told you, the midwives going very frequently within the first month of
Yes, okay.
baby.
I think, Tanuja, the thing is that actually what we need to, I suppose, consider is that there are two levels of this. One is practice by individuals and the teaching, and the other one, which I'm interested to know, and I don't know how people feel about this, is organization, administration from centers, that is to say, local government, local public health services. How does that work? I mean, this is a bigger question, isn't it?
Yeah, thank you. And so I think what we heard from Sri Lanka was both, on the practical elements, some of the tips that would really help someone who might feel like, oh, maybe it's not worth it if the baby's going to cry or howl, to the systems issue, which you mentioned, that this is part of a final examination. People are equipped to be able to do this, and you've been able to integrate this kind of approach to sort of being baseline, capacity for someone who's going to be examining newborns. So I think both those things are very interesting. But I know Dr. Alex was very keen in hearing from other contexts. What stood out for you in terms of thinking about your own context and this phenomenon of isolated cleft palate? What are some questions? You can feel free to type them in the chat. You can turn on your camera and ask a question directly, but we'd love to hear from you. We've got a variety of people from around the world. What stood out for you?
Buen día, no sé si me pueden escuchar. Soy de Perú, soy Nora Ruiz. Bueno, acá en el hospital donde yo trabajo hay muchos casos que han venido pacientes que recién acá en la evaluación es que nosotros hemos visto la fisura submucosa generalmente, ¿no? Entonces, esto nos indica que hay muchos casos que no están siendo evaluados desde pequeñitos, ¿no? Entonces, las mamás ya comienzan a referir cómo fue, sí, no se alimentó bien y todo eso, pero no se detectó, ¿no? Recién cuando ellos vienen, ya cuando el niño ya tiene 3 años, a hablar, tiene mucha dificultad. Entonces, al tener toda esa dificultad, ellos la traen a la evaluación con el terapeuta del lenguaje, y es ahí donde nos percatamos que el paciente tiene una fisura, pero que no se detectó desde pequeñitos, ¿no?
Thank you, Nora. So this is Nora from Peru, and her observation is that, and I think that was very fast, Nora, but I think that the observation was that yes, that that a very small hole, Dr. Alex, as you mentioned, is often overlooked. And I'll ask my colleague Jalexis to jump in if I missed something there. But that sense that a very small palate can be missed, and that obviously causes problems. And Dr. Alex, I noted from your findings that a child who looks otherwise, as expected, is less likely to have their isolated cleft palate detected than a child who has other syndromic features, and then is more likely to have a more thorough investigation. Did I understand that correctly, Dr. Alex?
Yes, that's absolutely correct. But what I'm interested in, you're absolutely right. 2 good points. Thank you very much in that. And thank you for the comment from Peru. This question of smaller clefts, which is why it's so important, as Sanuja has actually pointed out, is that you have to be opportunistic, but the thing is that you must still be thorough, so that actually, if the baby doesn't happen to cry conveniently, sometimes babies don't always cry conveniently in the way that so you still need to apply a spatula. And I think one has to do that. But I'm also interested to know how it would be viewed, something like this, in other contexts. In your context, these are Caucasian babies by and large that are being looked at on this video and on my material. And I don't know how it is perceived in other parts of the world. And I'm very interested to know.
Alex. Yes, we'll put that out. Anyone have a comment or question about how this type of training material or this practice would look in their context? And a great thanks to Nora for kicking us off.
Yeah.
I mean, one observation that I'll make as I wait for others to either type a comment or a question or put their hand up to ask a question is, the people on this call obviously they're cleft professionals. They're used to looking for clefts. They have, when a baby comes in, that's the first thing they're looking for is some of the telltale signs that a cleft lip or palate might be involved. The key gap I would expect in many of the contexts in this call is that sense of how do you get to the other folks who think about cleft, once a year or maybe never, they've never really thought about cleft in a detailed way. How do you get them to move to that stage of actually having that, that ownership, I guess, as you mentioned, of that really inspiring story of a midwife who made it her practice, we will have no missed isolated cleft palates in my practice for 5 years. I mean, that sense of ownership I thought was very helpful. And I'm wondering about how we could, both raise the awareness, but also, extend that invitation to take ownership of this as a key element that could be incorporated into every maternity hospital's practice.
Right. One of the ways, of course, is by showing them the effect of not identifying, not finding them, and the sadness and misery that can be caused long term. And if people can grab hold of that, that seems to be a very core motivator. But maybe other people have had different experiences and can tell us what they have found motivates staff, people in their services to come forward and make it a mission.
Thank you, Alex. I see Carolina from Costa Rica, please.
Hi, good morning. Well, I will explain my position as in speech. Here in Costa Rica, normally doctors do not have the training when babies are born to check the mouth and also to touch the palate. So sometimes here, in the moments that we find this isolated clefts are when they're at school, like 4 to 9 years, and they have speech problems. So it's kind of sad, and I understand the doctor, because sometimes we can work more or do more for the patient earlier than the age of 9 or 10. For me as a speech, I feel like kind of pressure because we need to work for correct the articulation problems and then prove to doctors that there is a need for surgery.
Yeah, that's crucial, and thank you for that comment, because the work that we also did with Parakrama and Tanuja in Sri Lanka was on what is the upper limit that you can expect good speech outcomes, and in terms of age at surgery. And I don't know, Para could probably comment more forcefully on this about what you consider to be the age within which you can get a good result.
Oh, you're on
You're
mute. Yeah.
What we are actually practicing in our country, basically the normal protocol which is followed in the Great Ormond Street. Usually the lip repair we do around 3 months and the palate repair 9 months. Sometimes the palate get delayed if the patient is having other medical problems, which is not suitable for anesthesia. So otherwise, usually what in our setup we have seen, they are starting the speech around 9 months. So at that time, we think it's the best time to do the palate surgery. As so another comment regarding the detection, usually the palpation method, the midwives are a bit reluctant to do that, to put the finger in and then palpate. So I think we can educate the people about the techniques of detection, like RCPCH videos. They are very helpful. So we can actually using that as a teaching material to teach them how to do it, how to detect it. And then probably if it's necessary, then the professionals can come in and then detect. Even the parents can, we can advise them regarding what are the things to be looked with the cleft patients. So instruction booklets and videos can be produced. And now with the internet, we can easily download relevant videos to them. So all of them are having smartphones, I think now, most of them. So they can actually get through it and then find it out. So that may be a good way of educating more people about the detection.
That's a great point. And I think even as a non-cleft professional, I mean, seeing the video that Dr. Alex showed us, really helped me visualize exactly some of the challenges, even imagining, oh, right, like a baby's not going to want you to put a tongue depressor near it, as well as seeing some of the ways that could be missed. So I think that was very illustrative. Professor Michael, please.
Thank you. Excellent presentations. Thank you very much. My experience has been in examining the young children is that if you do elicit a gag reflex, you get a much better view of the palate. So while it seems cruel and unusual, you certainly get a much better view. So I tend to encourage my residents and students, go ahead and make the child unhappy once, but then you get a complete view of the palate. The second thing is that most delayed palates that have been sent, cleft palates have been sent to me, have all been secondary to just basically submucous clefts. Sometimes a bifid uvula, but mostly submucous clefts without a bifid uvula. And those patients either have speech problems, as Caroline mentioned earlier, or they get what has been referred to me or for stress-induced velopharyngeal insufficiency, so that after lengthy time speaking, their muscles fatigue and they get hypernasality, or people that play wind instruments and play a bugle or a saxophone, something where they have to force air through something, their muscles fatigue quickly and they're unable to play their musical instruments. And again, they're straightforward to treat, but those are the two types of things, either speech or the stress-induced velopharyngeal insufficiency, and they're submucous clefts. I guess in my experience in university hospitals, the babies get examined by so many people after they're born that they're rarely missed, not never missed, but rarely missed. So excellent presentation. Thank you for your brilliant presentation to us. Thank you. Thanks, you.
Michael. I see Anne, please. What's your question?
Thanks, Hugh. Hi, everyone. Ann Arnold, from Senior Director of Education and Training at SmileTrain. And I'm commenting on your question, Hugh, about training and what motivates people. And I have a lot of experience in women's health, specifically OBGYN, ultrasonography, and radiology. So having trained a lot of doctors, and I'm rather new at Smell Train, I'm about 9 months in here. But what I wanted to say is in my past, when I have developed training for doctors, and I have about 8 years of experience, I found it really effective, and there's a lot of literature to support this. I think it's really helpful to develop online modules. So what you do is you can develop ideas, like basically show everyone, or you can review all of the things, like how do you identify, in the cases when I did this, how do you identify a breech birth? What happens? What are the signs? And then so that they have this information before they go in for the one-on-one instructor-led training. So basically what that does is it really reinforces a lot of the things that are covered in the lecture, because they've actually visually seen some of those examples. They select examples like right, and they're like reinforced right or wrong. And you can also develop point-based gaming into like a review of information. And that's really effective, especially if it's like shorter modules. So those are my 2 cents for today. Thanks, everybody.
Thanks, Anne. Glad you could join us, and thank you for bringing that experience from other health topics to here, where
Sure.
the folks on this call are the ones beating the drum for cleft, right? And again, it's not so much potentially. I mean, obviously we have things to learn from the specific tips that we saw on the website from the Royal College in the UK, but also, how do we bring that kind of passion to say, there is a small cost, as Professor Michael mentioned, it might make the baby a little bit uncomfortable, but the reward of detecting it early, as Jennifer from Brazil points out, speech outcomes. We even have the missing, isolated cleft palates in somewhere like Uganda that Andrew Hodges points to, saying maybe these kids don't make it. I mean, the costs are quite high of moving on in this idea of where, in the UK, we even saw 30% are not diagnosed within a week. So lots of great ideas brought here. I know that Dr. Alex is very keen to talk more about you and your context of how we could expand some of this training, maybe in the ways that Anne talked about, of making sure that everyone who sees a newborn has that idea, whether it's a midwife or a pediatrician, an attending physician, who really senses, this is a simple thing I can do that will lead to really long-term impacts that are positive in every case. So I'll go back to Niti quickly to sort of close us off. As I mentioned, we always start and end on time. I know we really are grateful that you've made some time in your day, whether it's the morning, midday, or evening, to do some learning and some conversing with us. Niti. Oh, we don't hear you.
Thank you so much. That was such a wonderful webinar. It was so informative and eye-opening, honestly. So yeah, just to close this off, we invite you to subscribe to our YouTube channel, Circle of Cleft Professionals, where you can access all of our previous webinars, including this one, which will be posted soon. You can also join in on Twitter. Our handle is @CleftCircle. If you have any webinar topics or presenter suggestions, any queries, or else would like to share any articles or other materials for our website, please email us on info@cleftcircle.org.
And also, if you have a great question that you'd like to get in touch with Dr. Alex, and that's a great way. We'll pass that along. If you send us a quick email, info@cleftcircle.org. I know he's very interested in moving forward and saying, what can we continue to learn from the UK experience that might be applicable in LMIC context? And I think we've established that there's a great payoff for that if we can move forward. So thank you for joining us today. Thank you, Wedise, also for your great comment about how this plays out in Ethiopia. We've had participants from around the world today, so we're delighted and hope to see many of you either virtually or in person in Edinburgh. This will be our last webinar until after the conference, and we know many of us are getting ready now to participate in various ways, including, I think, a couple papers, as Dr. Alex and I were talking about, on this very topic. So there'll be more chances to deepen our knowledge and our understanding of how to spread this word about isolated cleft palates around the world.
Thank you. Thank you very much for the opportunity, Hugh, and Niti for managing so nicely. Thank you.